A very good morning to everyone. First, I would like to thank Arvind Hospital and Dr. Balraj sir for inviting me to give this lecture. So it is a very vast topic, this demyelination, but we'll give a glimpse about in this short time. Deciphering neuroradiology findings in demyelinating disorders. So what is demyelination basically? It is a loss or a damage of the myelin sheath surrounding the nerves in the central nervous system. So that is basic. So it involves both the brain and as well as the spinal cord. With regarding to the orbits, it's the optic nerve. So what is the role of radiology in this? Among the modality of choices, MRI is the gold standard. CT and PET-CT, definitely they have very limited role or even null role. In MRI, so what are the sequences that are required? We do a T1, T2, flare, DWI and post contrast. So these are the basic sequences. Among these 5 sequences, flare is the important sequence. That is the sequence where we have to look for. And T2 is also important. And DWI is a sequence where if restriction is there, which we'll be seeing in the coming images, it denotes the activity of the lesions. So that is the power of that sequence in demyelination. What is the role of contrast? Sometimes it is required, and some lesions only enhance and some doesn't enhance. In activity of the lesions, in remission and in follow-up, it plays a good role. And most of the demyelinating lesions like multiple sclerosis, they have the spinal cord lesions also. 85% of the MS lands with spinal cord, or in thoracic cord also the lesions will be seen, or screening of the spine is also mandatory in this. So what are the most common differential diagnoses? Only that we will discuss here. Multiple sclerosis, acute disseminated encephalomyelitis, neuromyelitis optica spectrum disease, and the progressive multifocal leukoencephalopathy. So considering the imaging pattern, the good clinical history, and CSF analysis, we can narrow down the DDs with the help of radiology. Only with help of MRI or radiology, we cannot diagnose this. We are only going to give the closer differential diagnosis for the clinician. So in spinal images, MRI spine, the multiple hyperintense lesions, that is the white lesions, will be seen there. So they are mostly seen in cervical and thoracic cord, may show contrast enhancement or they may not also show. So first thing is MS. So the type of lesions is, they are juxtacortical or intracortical, in the cortex or next to the cortex. They are periventricular. So this will be representing as the dorsal fingers in flare sagittal. So these are T2 sequences, and this is a flare sequence. Infratentorial, below the tentorium, it is seen in the cerebellum as well as in the pons in the brainstem and the spinal cord. These cigar-shaped lesions, these white lesions, these are seen in the spinal cord. So these types of lesions will be seen in multiple sclerosis. In comparison, MRI definitely helps a good role. So this is a baseline investigation which was done initially. So there was a lesion, this was found to be MS. But in follow-up after 3 months, there was a new lesion seen there. So comparing with the previous records definitely helps here. So these are the T2 sequences. So this is a contrast sequence. So this is how the contrast helps here. This was a baseline investigation in the right side. There are 3 lesions are noted. But what happens is that the same patient with the same axial section, the number of lesions have reduced, but a new lesion is found on the right occipital lobe. And in the contrast, this enhancement is picked up. So what are the typical for these MS lesions? Juxtacortical, next to the cortex, in the cortex, the dorsal fingers, the brainstem lesions, temporal lobe involvement, corpus callosum or pericallosal involvement, spinal cord lesions. So one of the closer differential diagnoses for this multiple sclerosis in age-old patients who doesn't have this clinical history, and just like that they walk in, we found this commonly above the age of 50 years with either with the hypertension or hypercholesterolemia or with the diabetes, this small vessel ischemic changes. It's a usual finding, which we do that. So how to differentiate from this? In MS, suppose if it is clinically suspected, we found the lesions in the cortex or in the juxtacortical and in the periventricular. They will be perpendicular in the periventricular area. And we have to zoom the images nicely to see whether the U fiber involvement is not. These U fibers involvement we don't find in small vessel ischemic changes. So these are all certain differentiating points here. This everybody knows here. What is called as the Dawson fingers. The periventricular multiple lesions are noted here, like a sunray appearance. No, they are perpendicular to the ventricle. It goes along the perimedullary veins, and this is the axial sequence. So here, this perpendicular thing is noted here. In brainstem, we found this MS lesions. So in the right side, this image, it is a case of small vessel ischemic changes. How the pattern of spread is there? It is seen in the central part of the pons, right? So almost it is symmetrical. But whereas in multiple sclerosis, we found these lesions in the periphery. They are asymmetrical. So one lesion is here. So one is here near the trigeminal nerve. One is next to the fourth ventricle. So there is a difference, right, between the small vessel ischemic changes and with patients presenting with MS in this fashion. So this was our case done recently, a very early stage of MS. This is a flare sagittal sequence and it is a flare axial sequence. These two sequences are more than enough for this to look over these hyperintense lesions. Rest of the lesions will give a supporting role in that. Look at the multiple, the hyperintense lesions are noted here. No, these are all flare sagittal sequence and multiple hyperintense lesions are noted in the pericallosal area. They are perpendicular to the ventricle along the perimedullary veins, forming the early Dawson finger. In axial sequences, the Dawson fingers, what we are seeing here, it presents like this. And definitely, this is the case of same MS. It's a baseline investigation here. And this is in the contrast, a new lesion is found on the right occipital lobe. There is something called tumefactive demyelination. So this presents exactly like a tumor or an abscess, but still it is demyelination. So how do we differentiate that? So here you can see there is a lobulated, a T2 hyperintense, a cystic kind of mass here. So initially it looks like as if we are dealing with some mass lesions, a glioma or an abscess. But what is happening here? This white matter edema is noted. Can you look over? There is no significant midline shift here. For such a huge lesion and there is edema, there is no midline shift or not much of the mass effect. And in the contrast, we see this open ring sign. This open ring sign we see mostly in a demyelination. In abscess, it will be a thick-walled or a thin-walled enhancement. In gliomas, depending on the gliomas, the enhancement pattern may vary, either poor enhancement or peripheral enhancement or butterfly type of enhancement, whatever it may be. So this open ring enhancement we see in a tumefactive type of a demyelination. So this is a contrast image here, post-contrast image, and T2 such a huge lesion with vasogenic edema, but there is no midline shift and mass effect. So this is how we narrow down the DD2 tumefactive demyelination. So what is that multifocal lesions? How do they present in the spinal cord? Around 85% of the MS, they have the lesions in the cervical cord. So cervical region is more common than thoracic region. Most of the lesions in the spinal cord are in the periphery. So the central medullary part, we have the peripheral part. Mostly they are peripheral. They are short segment. They are not continuous. They are short segments. And some may have the focal swelling of the cord. Some may have the focal atrophy of the cord. Enhancement is not mandatory. Mostly the spinal demyelinating lesions, enhancement is uncommon. So this is how the MS lesions presents in the spinal cord. Multiple lesions are noted. These white lesions, they are cigar-shaped lesions. They don't form a pattern actually. They are seen in the periphery and they are asymmetrical in pattern. They are not long segmented, right? They are not continuously seen in the cervical and the dorsal spinal cord. Bit pieces, these T2 hyperintense lesion, no, this is how they present in cervical spinal cord. We have to zoom it nicely and check it. So sometimes incidentally also we picked up in the spinal screening cases, we found these type of lesion. So immediately a brain screening is mandatory in that scenario. Suppose if we found the similar lesions in cerebellum or in brainstem, then we are narrowing the DD to MS. So this is a case of a small vessel ischemic changes. See, look at how these hyperintense lesions are seen. They are diffuse, right? They are mostly seen in the frontal and the parietal lobes. They are not like MS. MS lesions were punctate lesions. They are subcentimetric. They were well defined. They are juxtacortical. They are intracortical. But here it is located mostly in the deep white matter. They are not juxtacortical. They are not intracortical. We don't find any dorsal fingers. And add on to that, some atrophy changes in the brain is noted. And there is a lacunar infarct in the gangliocapsular area. So this widespread white matter disease with a symmetrical distribution. So this is how we see in small vessel ischemic changes. And these are the points to differentiate between the MS and small vessel. In small vessels, we don't find this corpus callosal or this pericallosal involvement and all. The U fibers is predominantly seen in multiple sclerosis, but not in SVD. And supratentorial, infratentorial and all we see in MS, but small vessel ischemic changes has no role in infratentorial, maybe in the later stages. Enhancement pattern, MS, sometimes we see enhancement, but small vessel ischemic changes, never. There is no role for contrast to enhance in the ischemic area. And SVDs are mostly, they are symmetrical, but multiple sclerosis are not like that. They are asymmetrical. And the black holes, they are typical in multiple sclerosis, but they are rare in SVDs. And spinal cord lesions, MS, mostly they will have in cervical or in dorsal spinal cord, but small vessel ischemic changes has got nothing to do with spinal cord. The next differential in the demyelination is the neuromyelitis optica spectrum disorder, NMOSD. Once it was called as the Devick's disease. So here we see a long segment T2 hyperintense lesion in the entire spinal cord, right? In the cervical and the thoracic region. This is a long segment involvement. In MS, what we saw was the cigar-shaped lesions. They were periphery, and multiple lesions were not like this. So this must be nearly more than 15 centimeters. No, there's a long segment T2 hyperintense lesion. In the optic nerve, the optic nerve sheath fluid, sometimes we have the normal optic nerve fluid that is actually not seen here. And the optic neuritis type of enhancement is noted. So optic neuritis with the transverse, this myelitis like presentation with the brainstem lesions may or may not be present. This is NMOSD. Another DD is the Ballo's concentric sclerosis. So this type of demyelination, we find the alternating myelination and demyelination pattern leading to this striated type of appearance here. In contrast, we see this is striated type of enhancement here. In DWI, this is the DWI sequence where we see the peripheral restriction alone here. So this denotes the activity of the lesion. So this is a sequence called ADC in the what I am circling here. ADC, VDCC, this is the black line we are seeing now, that is the hypointense in the ADC. So this denotes that it is a DWI restriction is noted. That is the activity of the lesion is here. So progressive variant of multiple sclerosis, alternate bands of demyelination and myelination with lamellated and the skin appearance is noted. Next one is the ADAM, acute disseminated encephalomyelitis. So look at the type of a demyelination happening here. Of course, there are white matter lesions, no doubt about it. But if you closely look, there are these patchy hyperintense lesions, no? They are very big also. They are involving the gray matter, the subcortical gray matter. Also, the deep gray matters are also involved. They are involving the basal ganglia. These hyperintense lesions, no, this is a flare sequence. These hyperintense lesions are noted in the basal ganglia. This is the caudate nucleus, the lentiform nucleus, the thalamus is also involved. And apart from that, the gray matter is also involved, the white matter is also involved. So supra and infratentorial white matter with enhancement. So the gray matter involvement, they are diffuse and symmetrical, and they will be associated with the post-viral infection. This is ADAM. So next case is same of Adam with the thalamic involvement is noted here. And this is a contrast, and they don't show any enhancement here. See, look at the hyperintensity in the T2 sequence, but in contrast, we don't find this enhancement. But what is happening here in the left, in the infratentorial area, in the middle cerebral peduncle, there is a T2 hyperintense area. And the same case as a long segment T2 hyperintense lesion starting from the cervical medullary junction involving the cervical spinal cord and then to extending to the thoracic cord also. So the same case, it has multiple lesions here, right? This is a flare axial sequence. It is noted in the deep white matter with the edema. Even the brainstem is involved here. How the lesions are there in the brainstem in the seen in the periphery, right? They are asymmetrical actually. In the left side, we see the middle cerebral peduncle and the infratentorial, but in the right side, we don't see here. Look at the basal ganglia involvement is seen. The same case with the contrast, right? So how the hyperintense lesions are noted in the plain images in flare axial, but in contrast, only a speck is noted. That is where the enhancement pattern varies. It is not mandatory. All the demyelination should have a enhancement speck. Only one speck is noted here, right? Only these kind of specks are noted for such large lesions, what we saw in plain study. This is a coronal image of a T1 post contrast. This is a strip-like pattern type of enhancement is noted. So the same case of Adam only, it is involving the entire spinal cord here, right? The brain also we saw the lesions, and spinal cord also we are just seeing these lesions, right? So the one stroke imaging with the T2 sagittal, right? Even the brain also we can include in this cuts. The entire spinal cord is involved. Lumbar is mostly spared because the phylum terminal it ends at L1, no? So the cervical and the dorsal only it is mostly involved. This entire hyperintense lesion is the demyelination. They may be associated with the cord swelling, or they may be associated with the atrophy of the cord in later stages also. How to differentiate with the Adam and MS, right? So mostly it's monophasic. This is one is multiphasic, and there will be a viral trigger in Adam, but MS we don't know actually. It's not necessary, but Adam will be having a viral trigger. And a follow-up, actually, they have some full recovery, but new lesions may come in MS. And in spinal cord, we saw no those transverse myelitis kind of a presentation will be seen here. But in MS, those are short segment lesions. They are cigar-shaped lesions. They are in the periphery. In the brain, we saw how it was in the deep gray matter, in the superficial gray matter. It was in the thalamus and the basal ganglia. But in MS, we know what are the type of presentations. No, they're juxtacortical, cortical, intracortical. Dawson's fingers will be seen here. In Adam, we don't see this Dawson fingers and all. MS, the lesions are very short and subcentimetric, but here they are very patchy and they are very large in size. With the viral trigger history is important in Adam. Another differentials is PML, progressive multifocal leukoencephalopathy. The history is important to narrow down this DD because it comes mostly in immunocompromised. No? So the JC virus is one of the causes here. And look at the size of the lesion. This is a flare sequence. This is a T2 sequence. In flare sequence, we saw a big lesion here. No, in MS, we saw small lesions, but here, how big it is in the juxtacortical or in the subcortical area. And this is a drug-associated thing, natalizumab-associated PML is also known here. In DWI, we see some minimal restriction here, denotes the activity of the lesion. Contrast, there is not much significant enhancement noted in PML. So how to differentiate with MS with PML? MS, we know what are the findings, but in PML, the shape is diffuse, it is ill-defined, it is somewhat bigger in size than when compared to the MS, and it usually progresses in size because they are mostly immunocompromised patients. And this case actually was suspected to be a MS, but turned out to be a sarcoidosis. Now, all the patterns are actually similar to MS. Multiple T2 flare hyperintense lesions. They are very small. They are involving the deep white matter, even the juxtacortical, intracortical, the periventricular, the Dawson's fingers are also seen. But somehow the clinical diagnosis is the final. So that is where our radiology role is somewhat limited. So we can narrow down the DD only and give the possible differentials along with the clinical scenario. This case turned out to be a neurosarcoid. So CADASIL is another form. There is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It is seen in young adults, the patients who presented with migraine, dementia, and family history. So subcortical lacunar infarcts are noted here. Predominantly, the temporal lobe involvement will be seen here. So young adults with the leukoencephalopathy with this type of history, it is an inherited small vessel disease, an anterior temporal pole. We have this high signal intensity, then CADASIL would be a good differential. Coming to the spinal myelopathies, this demyelination. Suppose we when we are doing the whole spine screening, we found these kind of lesions. It's a long segment lesion, right? So it's a transverse myelitis, only confined with this we'll be thinking about the transverse myelitis, a long segment T2 hyperintense lesion that is noted in this dorsal spinal cord alone here. On contrast, there is not much enhancement in the second image. And third one is the stir sequence. So first one is the T2 whole spine sagittal, and this is a stir sequence. So these two sequences will throw better light in determining the demyelinating lesions. So this is how the axial section of the cord involves. The central portion. So transverse myelitis, we see this central type of involvement, whereas in multiple sclerosis, it will be periphery and patchy, not like this long segment lesion. So this was our case, suspected case of a transverse myelitis only. See how the lesions are there. Almost from C2 to C6 vertebrae, we found this. This is a long segment lesion. Then again, a patch is noted here. So this is the entire spinal cord screening, and this is a post-contrast. There is not much enhancement in the third image. This was a nice case because it was first treated for disc degenerative disease, right? Because there was a multiple disc bulges noted in the cervical spinal cord, even with the cord compression is also noted. But somehow later they found out that it is not clinically correlating. Then we did the MRI whole spine screening. We found out in the cervical spinal cord there is a T2 hyperintense lesion here. So this is a mix that is presenting with transverse myelitis as well as with C5, C6 disc prolapse in the spinal cord. So what is the conclusion? MRI is the gold standard and modality of choice in radiology for diagnosis and follow-up. CT scan and PET CT scan, they have a very limited role. Pattern recognition is the key to narrow down the DD. We saw all the patterns, no, this multiple sclerosis, how juxtacortical, intracortical, or with the Dawson fingers are there in the periventricular, asymmetrical, supratentorial, infratentorial, or with immunocompromised, we're dealing with the JC virus, any post-viral infection, we're dealing with the ADAM. So the pattern recognition is a key. Early radiological evaluation aids in management and prognosis, but the hallmark is a good clinical evaluation with clinical diagnosis and other laboratory investigations will be the final. We'll be just narrowing the DD to the clinician. Thank you.